Good morning. My name is Dr. Ahmed Mohsen from the teaching team in the cardiology department, Cairo University. It's my pleasure and great honor to share with you this lecture about management of heart failure. The main items of the management include diet, activity, drugs, and finally procedures. Let's start with the diet and activity. We should advise our patients to restrict the salt intake and to restrict the free water intake if they have manifestations of volume overload. We should assess body weight on everyday basis. We should advise for bed rest if he has decompensated heart failure, and we should encourage exercise as tolerated in compensated patients and under medical supervision. The drugs which are used for treatment of heart failure include diuretics, MRA or mineralocorticoid receptor antagonist, ACE inhibitors, angiotensin receptor blocker or ARBs, digoxin, beta blocker, ivabradine, and finally the most recent drug which is ARNI, angiotensin receptor neprilysin inhibitor or sacubitril valsartan. The diuretics. The diuretics is used to relieve the symptoms of congestion, either pulmonary congestion or systemic congestion. We have many preparations in form of furosemide with dose ranging from 10 to 500 mg per day. Torsemide, the dose is ranging from 20 to 80 mg per day. Hydrochlorothiazide 25 mg per day. Metolazone from 2.5 to 10 mg per day. The diuretics has no effect on mortality. It is used only to relieve symptoms of systemic or pulmonary congestion. The main side effects include hypotension, hyponatremia, or hypokalemia. The second line of treatment is MRA or mineralocorticoid antagonist. We have two formulations, spironolactone, the dose ranging from 12.5 to 200 mg per day, or eplerenone, the dose is ranging from 25 to 50 mg per day. The aim is to relieve the systemic and the hepatic congestion. It has a role in mortality reduction. It can improve mortality or reduction in the mortality. The main side effects include hypotension or hyperkalemia. The third line of treatment is ACE inhibitors and ARB. The main role is to decrease the preload and to decrease the afterload by inhibition of the RAS system with a subsequent inhibition of the neurohormonal activation. It can help to increase in the survival and reduction in the mortality. The main side effects include hypotension, hyperkalemia, worsening renal function, angioedema, or cough. The most commonly used ACE inhibitor include ramipril with dose ranging from 1.25 to 10 mg per day, enalapril from 5 to 20 mg per day, and finally perindopril from 5 to 10 mg per day. The angiotensin receptor blockers or ARBs include valsartan from 40 to 160 mg twice daily or candesartan from 4 to 16 mg per day. The same mechanism of action and the same benefit like ACE inhibitor, but it acts on the receptor itself rather than the ACE enzyme, and it also improves survival, and it has the same side effect except the cough. There is hypotension, hyperkalemia, worsening renal function, and angioedema. This nice diagram is showing the mechanism of action of different drugs used for treatment of heart failure according to the pathophysiology of the heart failure. In patients with heart failure, there is a reduction of the cardiac output with a subsequent reduction in the renal blood flow, which result in release of the renin from the kidney. Then the renin act to transform the angiotensinogen produced by the liver to angiotensin 1. Then the angiotensin 1 is converted to angiotensin 2 by the ACE, which is produced by the lung. The angiotensin 2 result in increase in the aldosterone and vasoconstriction and enhanced sympathetic activity. So when we give ACE inhibitor, we block the RAS system at this stage. So there is an increase in the bradykinin, which result in vasodilatation, and it result in cough as well. When we use angiotensin receptor blocker, we block the RAS system at this stage, so we prevent this harmful effect, including the increase in the aldosterone and the vasoconstriction and the enhanced sympathetic activity. When we give spironolactone, we block the aldosterone as well, as it acts as aldosterone antagonist, so there is no salt and water retention. We give diuretics to overcome the salt and water retention, and finally we give beta blocker to overcome the enhanced sympathetic activity. The most recent drug is the angiotensin receptor neprilysin inhibitor, which is sacubitril valsartan. The valsartan is angiotensin receptor blocker, and the sacubitril is neprilysin inhibitor. The neprilysin is an enzyme that is responsible for breakdown of the natriuretic peptide. So when we inhibit neprilysin, there is an increase in the natriuretic peptide, which result in diuresis and vasodilatation, which can increase the improvement in the symptoms due to reduction in the preload by natriuresis and reduction in the afterload by vasodilatation. And there is inhibition of the RAS system and the neurohormonal activation by the valsartan action. It improves survival over the ECI and the same side effect as ACE inhibitor, including hypotension, angioedema, and worsening renal. And this is how ARNI can work, or angiotensin receptor neprilysin inhibitor. There is an reduction in the angiotensin 2 by the valsartan So there is a reduction in the vasoconstriction and the sodium retention and the hypertrophic effect. And by the neprilysin, which is neuroendopeptidase inhibitor, there is an increase in the natriuretic peptide, which result in vasodilatation, natriuresis, and increase in the sodium excretion and anti-hypertrophic effect. Another important line of management of heart failure is beta blocker. In patients with heart failure, there is a reduction in the cardiac contractility with a subsequent reduction in the peripheral perfusion and sympathetic hyperactivation, which result in the following bad side effect: apoptosis, necrosis of the myocardial cells, as well as fibrosis of the cardiac muscle and muscular hypertrophy, which is called cardiac remodeling. So the beta blocker act to prevent this remodeling by blocking of the sympathetic hyperactivation. So the beta blocker include the following preparation: bisoprolol, dose ranging from 1.25 to 10 mg per day; carvedilol, the dose ranging from 3.125 to 25 mg twice daily; metoprolol, dose ranging from 25 to 100 mg per day. The beta blocker acts by inhibition of the sympathetic activation. Initially, it may worsen the symptoms, and the main side effects include hypotension, asthma, or heart block. Another important line of treatment is ivabradine, which acts on the SCA node by inhibition of the funny current in the SCA node, so it can reduce the heart rate. The main benefit is to reduce the hospital admission. The main side effect is flashes of light due to inhibition of the funny current in the retina. The dose is ranging from 5 to 7.5 mg per day. The digitalis is used as a last line option in patients with heart failure. It has a positive inotropic effect, which means that increase the cardiac contractility. It may reduce the hospital admission. It has no survival benefit. The main side effect is fatal arrhythmic toxicity or digitalis toxicity. The dose is ranging from 0.125 to 0.25 mg per day. It is used as a last resort option in patients with refractory heart failure on the previous medication. Digitalis toxicity is not uncommon as it has narrow therapeutic margin. The manifestations of digitalis toxicity can be classified into non-cardiac manifestations and cardiac manifestations. The non-cardiac manifestations include anorexia, nausea, vomiting, headache, disorientation. The cardiac manifestations include sinus bradycardia, sinus arrest, heart block, usually second-degree heart block, atrial tachycardia with AV block, development of junctional rhythm in patients with AF, and finally PVCs, VT such as bidirectional VT or ventricular fibrillation. What are the indications of anticoagulations in form of oral anticoagulation such as warfarin or coumadin in patients with heart failure? The indications of anticoagulation in patients with heart failure include atrial fibrillation, history of thromboembolic events, or left ventricular apical thrombus. What is the role of vasodilators in patients with heart failure? We have two types of vasodilator. The first type is arteriolar dilator, such as hydralazine. The second type is venodilator, such as nitrates. Hydralazine is used to reduce the afterload by causing arteriolar vasodilatation with a subsequent reduction in the left ventricular end diastolic pressure and a decrease in the oxygen consumption, improvement of the myocardial perfusion, stroke volume, and the cardiac output. While nitrate is used to reduce the preload by causing venous dilatation with a subsequent reduction in the venous return and reduction of the load on both ventricles. Usually, the maximum benefit is achieved by using agents with both action. In practice, we use ACE inhibitor as it results in both reduction in preload and reduction in the afterload. If we can't use ACE inhibitor, for example, in patients with markedly elevated renal function or patient with renal failure or patient with hyperkalemia, we can use hydralazine nitrate as a substitute for ACE inhibitor. Hydralazine is used to reduce the afterload and the nitrate is used to reduce the preload. But this is as a second line if we can't use ACE inhibitor. What about positive inotropic agent? Positive inotropic agents include beta-adrenergic agonists such as dopamine or dobutamine, dopaminergic agents such as dopamine, phosphodiesterase inhibitors such as milrinone or amrinone. Several studies showed that there is an increase in mortality with inotropic agents, especially milrinone or amrinone, so they only used in acute setting such as cardiogenic shock and for a limited period. Let's talk about heart failure with preserved ejection fraction or diastolic heart failure. In this type of patient, the ejection fraction is above 50% with typical symptoms and signs of heart failure and elevation of the PNB plus or minus N-terminal pro-PNB. The main line of treatment is to treat the underlying etiology. We can use ACE inhibitor and beta blocker to reverse the left ventricular remodeling or hypertrophy. We can use preload reducing agents such as diuretics or nitrates. We can maintain sinus rhythm to improve the left atrial contraction and reduction of the symptoms of pulmonary. So this is the summary of the drug treatment for patients with heart failure. We can broadly classify patients with heart failure into two major categories: patients who are at risk for developing heart failure, including stage A and stage B, and the other category is patients with established heart failure, including stage C or stage D. Stage A means that the patient is at risk to develop heart failure, but he has no structural heart disease or symptoms of heart failure, such as patients with diabetes or hypertension. The goal of therapy is to treat hypertension and to encourage smoking cessation and to treat the dyslipidemia and to encourage the regular physical exercise. This encourages the use of alcohol or cardiotoxic drugs, and ECI or ARB in appropriate patients for vascular disease or diabetes may be considered. Patients with stage B include patients with structural heart disease but without symptoms of heart failure, such as patients with previous MI, left ventricular remodeling including left ventricular hypertrophy, or low ejection fraction, or asymptomatic valve lesion. The goal of therapy include all measures under stage A and drugs such as ECI or ARB in appropriate patients, beta blocker in appropriate patients, and devices in selected patients such as ICD. Stage C include patients with structural heart disease with prior symptoms or current symptoms of heart failure, such as shortness of breath or reduced exercise tolerance or manifestations of systemic congestion. The goal of therapy include all measures under stage A and stage B, dietary salt restriction, drugs for routine use include diuretics for fluid retention, ACE inhibitors, beta blockers. Drugs in selected patients include aldosterone antagonist, angiotensin receptor blocker, digitalis, hydralazine nitrates. Devices in selected patients such as CRT or biventricular pacing or ICD, implantable cardiac defibrillator. Finally, the stage D include patients with refractory heart failure requiring specialized intervention, which include patients who have a marked symptoms at rest despite the maximal medical therapy, such as who are showing recurrent hospitalization or can't be safely discharged from the hospital without special intervention. The goal of therapy includes appropriate measures under the stage A, B, and C, and decision on the appropriate level of care and the options including an extraordinary measures such as heart transplantation, chronic inotropes, permanent mechanical support such as left ventricular assist device or LVAD. This table summarizes the drug treatment for heart failure. Stage A ECI or ARB, Stage B ECI or ARB and beta blocker, Stage C diuretics, ECI or ARB, beta blocker, aldosterone antagonist, digitalis, hydralazine nitrates, Stage D all the previous measures, chronic inotropes, non-pharmacological treatments. And this is a step ladder-like diagram for the use of the previously mentioned treatment strategy, starting from stage A and finally with stage D, which may end with heart transplantation or use of ventricular assist device. The non-pharmacological treatment for patients with heart failure include coronary revascularization if there is significant ischemia and viable myocardium, biventricular pacemaker or CRT if the QRS complex is wide more than 100 milliseconds, especially with left bundle branch morphology, implantable cardiac defibrillator or ICD if the ejection fraction is less than 35%, and finally cardiac transplantation or left ventricular assist device. So what is CRT? Cardiac resynchronization therapy. It is used for ventricle that don't contract at the same time, which means non-synchronized. So this can worsen the heart failure. Normally, the myocardium or the ventricle contract at the same time. In patients with bundle branch block, especially left bundle, there is a degree of left ventricular dyssynchrony, which means that not all fibers contract together, so there is an dyssynchrony. To overcome this problem, we use cardiac resynchronization therapy or CRT to help to pace, both ventricles at the same time, which means resynchronization, so increase the amount of blood pumped by the heart. So the CRT increases the cardiac efficiency. Permanent pacemaker is used for patients with heart block. We have two leads, right atrial lead and right ventricular lead, originating from the pulse generator. ICD, implantable cardioverter defibrillator. It looks similar to the pacemaker but slightly larger. It works very much like the pacemaker. However, the ICD gives shock, energy shock, similar to the DC shock, direct current cardioversion, that reset the abnormal heart beat back to the normal. Many devices combine pacemaker and ICD in one unit. On the left side, we can see the subcutaneous ICD related to the pectoralis muscle. It is used to give shock for ventricular arrhythmia, which is one of the important causes of the sudden cardiac death in patients with heart failure. The revascularization procedure, including percutaneous coronary intervention or PCI, which is used to treat the coronary artery disease, which is one of the most important causes of heart failure. This is a blood vessel wall with a significant atheromatous plaque and blood clots, result in reduction of the blood flow to the myocardium. We insert a stent after balloon angioplasty to restore the vessel patency and to establish the blood flow to the ischemic zone. The other option for revascularization is coronary artery bypass graft. The surgical procedures used for treatment of heart failure, including valve replacement or repair for patients with significant valvular heart disease, such as mitral or aortic stenosis or regurgitation. We can replace the diseased valve either by tissue valve or by metallic or mechanical valve. Another surgical option is surgical ventricular restoration for patients with left ventricular aneurysm. The aim is to restore the normal elliptical shape of the left ventricle instead of the spherical or globular shape using the aneurysmectomy technique, then interventricular patch to help to restore the normal left ventricular shape with a subsequent improvement in left ventricular performance and contractility. And now let's talk about acute heart failure. The main clinical finding in patients with acute heart failure is severe acute dyspnea, pink and frozy sputum or blood-tinged sputum, cyanosis, orthopnea, moist rales or crepitations, and wheezes. The main lines of treatment of acute heart failure include reduction of the high preload by reduction of the volume overload by using diuresis such as Lasix or furosemide loop diuretics, reduction of high afterload by using vasodilators such as nitroglycerin or Tridyl, and improvement of the pore contractility by using of positive inotropic agent. Let's see this algorithm for management of acute heart failure from the European Guidelines for Management of Heart Failure 2016. The first phase is called urgent phase after the first medical contact. We must exclude presence of cardiogenic shock. If there is evidence of cardiogenic shock, we should provide circulatory support either by drugs or by mechanical support. If there is no evidence of cardiogenic shock, we should exclude presence of respiratory failure. If there is evidence of respiratory failure, we should provide ventilatory support in form of oxygen, non-invasive positive pressure ventilation or CPAP or BiPAP, and finally mechanical ventilation. If there is no respiratory failure, we should identify the cause of acute heart failure in the intermediate phase, which is the initial 60 to 120 minutes, and immediate stabilization and transfer for ICU or CCU in all cases. What are the most common causes of acute etiology? It is called CHAMP. C stands for acute coronary syndrome. H stands for hypertensive emergency. A stands for arrhythmia. M stands for acute mechanical complications such as acute mitral regurgitation or ventricular septal rupture with myocardial infarction. And B stands for pulmonary embolism. If any one of these items is present, we should start the immediate specific treatment. If none is present, we should continue the diagnostic workup to confirm the acute heart failure and the clinical evaluation to select the optimal management. So, at the end of this lecture, you can answer the following. Why heart failure is an important disease? What are the types of heart failure? How to diagnose heart failure? What are the causes of heart failure? What is the next step after discovery of the heart failure? When to initiate and how to select the anti-failure drugs? How to manage heart failure with normal ejection fraction? How to manage refractory heart failure? And how to manage acute heart failure. Thank you and best of luck.